Well, I certainly want to welcome our CyberSite community to another great webinar. Today, we're having live surgery by Dr. James Lehmann from San Antonio, Texas. James has done prior surgeries for us, and today he'll be demonstrating complex cataract techniques with dense cataracts. So, James, thank you so much for joining us. I know you've been bouncing around the globe these days, and making time for this webinar is most appreciated.
Oh, thank you, Hunter. And thanks to all of you guys there in the cybersphere. I'm coming to you from San Antonio, Texas, and we're going to be doing two live surgeries today, both of them cataract surgeries. We'll get into the details here in a sec, but I'm going to start by just talking briefly about doing a brief lecture about cataract surgery, and then we'll move into the surgery. So I'm going to do a screen share right now. My name is James Lehmann. I'm in San Antonio, Texas, and I've worked with Orbis for the last 20 years. I started as a staff doc, and I've had the opportunity to travel around the world teaching cataract and cornea surgery. These are the topics that we're going to review in the lecture: nucleus disassembly techniques, conversion to extra cap, management of a PC tear, and then just a few grab bag themes that we can talk about at the end. So when we're talking about removing a cataract, there's basically like 4 or 5 different techniques that you can do. The first is divide and conquer. And that's what I'm going to demonstrate in today's webinar. It's what I do still after doing cataract surgery for the last 15, 16 years. You can pretty much get rid of any cataract with this technique. And then while it's not the fanciest or kind of sexiest technique out there, it's very efficient. You also things like pre-chopping, stop and chop, and then the different vertical and horizontal chops that we'll talk about as well. And so again, this is what I'm going to show today in the webinar. And for those of y'all out there that are learning about cataract surgery and doing your first 100 cases or so, I really say stick with divide and conquer, because once you master this technique, you can try some of the more difficult ones, but this is kind of the bread and butter. And so you can see here in this video is I'm doing a cataract surgery on a moderately dense cataract, and I'm making the first trench, okay? And so the thing is, you want to make about 80% depth. People always ask, how deep do you go? And the way that you know is once you're about 80% depth, you start to see perpendicular stria in the bottom of the trench. You start to see a little bit of the red reflex and these perpendicular stria, and that's how you know you're far enough. In terms of depth, you want to go, like I said, about 80% and width about 1.5 tips of the phaco needle, which is about 1 millimeter. And so once you get to that point, you know you're at the right spot. I'm looking right there. I can see that I see those perpendicular stria. And then I'm going to put in my second instrument, which is normally a Nagahara horizontal chopper. And then I'm able to fracture that nucleus. And so that's what hopefully you'll see going smoothly today in the cases. On the concepts of cracking, so I got to move back one here. This is my favorite second instrument, the Nagahara chopper, no financial interest. And the reason I like it is because it has a blunt tip and it's very narrow, so you can put it in the trench. But basically what you want to do is you're going to kind of roll your fingers like this, and you're opening it this way. It's not pushing down. That's the most common error I see beginning phaco surgeons do, is pushing too hard posteriorly. You can see in the little illustrations here on the right, you basically kind of want to roll your fingers, and that causes the instruments to spread like this. That puts the least amount of stress on the zonules and the posterior capsule. And I like to break the first heminucleus, but I don't have to crack it all the way through, just in that quadrant. And then I rotate 90 degrees. If I can't rotate it, if I can't crack it, I'll just rotate 90 and I'll start sculpting again and kind of trying that again instead of keep trying to do the same thing over and over. So we'll try to illustrate that. So again, we're putting both instruments in the trench there. Then we're rotating 90 degrees. Then you're going to see me make another trench. Now that we've already cracked it, we know what the depth should be. It's a little more easier to visualize. And then I put the other instrument in the trench there, and I free up that nucleus. Excuse me, that fragment. Okay, so I think this is a good break to move to the surgery, and then I'll come back and we'll talk about different techniques.
Thanks, Dr. Lehman. And while you're setting up, I can just basically present a little bit about this patient. This is a 60-year-old man who has a bilaterally dense cataract. He's legally blind from cataract blindness. And what's interesting about this patient is that they've had prior trauma where they were in a motor vehicle accident approximately 40 years ago and have had 2 reconstructive plastic surgeries with some involving the right orbit. So obviously today we're going to be operating on the left eye. For those in the audience, the cataract was so dense that we were not able to do optical biometry, but immersion ultrasound was done. So James, Dr. Lehmann is going to be doing surgery on the left eye. One of the things I appreciated that Dr. Lehmann mentioned is how important it is to master, divide, and conquer. If you look in the chat, you will see I'll be sending out a course that talks about the fundamentals of phacosurgery. I think divide and conquer is a great default. I think everyone should start off that way so that they really understand how to move within the eye and create cracks before you try to do things like stop and chop. So please know that divide and conquer is a wonderful technique that you can use on almost every single cataract. And there are experts like James who've done thousands and thousands of cataracts, and that is still their preferred choice. So just because you want to move to chopping and all that doesn't make you a better cataract surgeon. What makes you a great cataract surgeon is doing the best techniques that are in your hands and give you the best outcomes.
So hi, welcome everybody. Now we're looking through the microscope, so you're seeing what I'm seeing. We got patient Mr. O here, and we're going to be getting started. You can see here, I put some viscoelastic on the cornea. That's to help my staff so they don't have to put BSS every few seconds. If I move the eye gently like this, you can see it's a fairly dense nuclear cataract of decent red reflex, but you can see the density causing kind of a little opacity there in the middle. So we're going to get started. I like to use a 15-degree blade, and I'm sitting temporally, so I'm going to go about 40 degrees from where I'm going to make my main incision. I'm going to enter the eye, making about a 1 millimeter incision there. And then we're going to inject a little bit of lidocaine with epinephrine, or known as sugarcane. Okay, and now just to illustrate my doing the rexus a little better, I'm going to put some vision blue in the eye, even though with this eye, I think we could get away with not using it. But I don't ever put an air bubble. I don't think you have to protect the endothelium from the trypan blue. If the endothelium is healthy, the trypan doesn't stain it anyway. So I let it like simmer there for about 10, 15 seconds. And then I'm rinsing it out with basic salt solution here. And then you don't have to get it all out because the viscoelastic will do a job. This also helps to show your paracentesis. The beginning surgeons always kind of lose that. So that's a nice step. Those of you watching from South America and Africa and other places have pretty dense cataracts. And so it's not a bad idea to use trypan on every case if it's available. So now we're putting in a dispersive viscoelastic. You can see the chamber deepening and flattening of the anterior curvature of the lens. And then I'm going to use my 0.12 forceps, but I'm not going to grab the eye. I'm just going to close them, and I'm going to insert them into the wound to stabilize the eye. And then I'm going to move, I'm sitting temporally. So this is basically right in front of me. And I'm going to tilt the eye forward a little bit. I'm going to make a little bit of an incision there. And then I'm going straight up till that little mark on the knife like that. That gets me a nice square type incision. It's approximately 2.6 millimeters. Now the next part is the capsular rexus. Here's my cystotome. I'm going to enter the eye. I'm entering perpendicular. I'm going to rotate it 90 degrees like this. I do the same rexus every time, okay? I always start right here. I go to that and I push it forward a little bit. I like to do the rexus counterclockwise. And when it's blue like that, you can see it nicely. So there we have a nice flap. And in an eye with a dense cataract, you want to make a moderate size rexus. You don't want it too small or it's hard to take the pieces out. So I'm going to make one that's about 5 to 6 millimeters. It's ideally it would encompass all of the optic of the IOL, but that's not the end of the world if it doesn't. So you want to err more on the side of a larger one than a smaller one when it's a dense nucleus. I always regrasp in the same places, and you're like leading it forward. I'm leading it over here. So I'm not going out here. You're always thinking one step ahead. I'm bringing it this way. And a little maneuver, like let's say it starts to go out. Like let's imagine that's there. What you can do is the little maneuver where you grab it here, you come underneath and finish it like that. That's a good way to rescue a rexus that's going out. I didn't need to rescue that one. I just wanted to demonstrate that technique. Now we're going to do hydrodissection. And for you beginning surgeons out there, you definitely want to do good hydrodissection. You have to be able to demonstrate, there's that wave, and then I blot the lens. You want to demonstrate that you can spin that nucleus. Until you can spin it, you don't want to go to the next step. So here I am. I'm spinning it freely, so we know we're good. I'm going to be able to rotate that nucleus. So now my assistant's handing me my phaco probe. I'm getting my petals in order. And then I look at the tip of the phaco. So I'm going to zoom out here a little bit. Okay, my phaco tip, that's not exposed enough. So what I want to do is I'm twisting the collar until I'm about right there. You want the ports facing perpendicular to the needle. And I use a 45-degree tip. I'm going to go back to the eye, get in focus. And then I use automatic irrigation. So I'm kicking to the right with my foot. And then I'm entering upside down so that I don't hit into the iris. Now I have to rotate the lens, the phaco tip, 180 degrees. And now I'm in the correct orientation. Now I'm going to go to next step. This is like an aspiration or a quadrant mode, just to eat that capsule there. And I'll remove a little bit of viscoelastic here in the middle so it improves my view. You let me know if I get uncentered, okay? But now I'm going to start with that first trench. I'm going to go, people say how far to go. Go from one end of the rexus to the other, okay? You can go like slightly under it, but not on the first passes. Now I'm just creating space here. Just creating space. So I'm eating about 1 millimeter into the lens, and then I'm going to make that initial trench. So you can see the lens is moving a little bit. Did you see that? We don't like that. So we're going to go to dense cataract mode. You want to be able to cut it nice and clean. Thank you. So now it doesn't move as much. You see that? So you should have a second setting on your machine for dense. And remember, I was talking about what kind of width do we want on this? We don't want just one phaco tip. It's hard to put instruments in there. So we're going to go half a phaco tip this way. Also, I'm holding this with both my hands. My left finger here is stabilizing the tip while I'm still holding this instrument in my hand, the second instrument. So I'm realigning that trench. And now you can see the lens, it's so movable that it wants to spin when now we got about a 1.5 width trench. And I'm going a little deeper. I'm about 1 millimeter under the rexus on that side. Now I'm improving my visualization there. You can see I'm not at that point where you see those stria. There's still white in that. So I'm going to go deeper. Okay, now you're starting to see those perpendicular stria right there. That tells me I'm the right depth. Now, I'm not going to crack the heminucleus all the way across, just in this quadrant. So I don't have to be as deep on this side, but I want to be a little deeper in the center. So I'm going to go a little deeper in the center here. Okay, so that should be the appropriate depth. So now I'm going to insert my second instrument. And then we're able to crack it very nicely. But look, I didn't worry about cracking it all the way to here. I just did enough motion to crack it in that quadrant. So now I'm going to use my second instrument, rotate the lens 90 degrees. And then I'm doing the same thing over here. Now I know what depth I have to go because I've already cracked it once. So that was a lot faster. I found the depth very easily. Crack that quadrant. Rotate 90 degrees. You guys can open and load the lens if you haven't, okay? Okay. All right, again, easy depth right there. Put both instruments in the trench, and then it's a motion like this, like that. That's what I'm doing. Now the last heminucleus. I start in the middle. I'm going forward about 1 millimeter underneath the edge of the rexus. Going a little bit deeper. So now I know I'm the right depth because I see clearly where the bottom of the cataract ends. So now I'm going to crack this. All right, we're good. So now I'm going to go to a mode to remove the quadrant. And I want to find the quadrant that's the most mobile. So I don't pick the biggest one. That's the biggest quadrant. So I'm going to rotate 90 degrees. And I'm going to grab this little booger. And where I'm going to get it, I'm going to rotate my needle tip 90 degrees. And I'm going to go engage it right under the anterior capsule. And then I lift it up into the iris plane. And I have a mode for quadrant. And then I'm not moving much. You can see I'm letting the phaco tip do the work. I'm letting my second instrument feed the piece in while it dances on the tip of the phaco needle. So I'm not sitting there darting around the anterior chamber. I'm keeping the tip relatively stable, just above the iris plane. And I'm about halfway down on the pedal, eating all the pieces. Right again under the anterior capsule. And there we go. All right, now the last piece, I remove my second instrument. You may ask, well, how are you going to protect the posterior capsule? It's not needed. With modern phaco machines, the flow is so good, you're actually making it worse by having a second instrument and having liquid bleed out of that paracentesis. I mean, you'll see no surge after this eats this last piece here. And really, even an infinity type machine generation is fine. See, there was no surge at all. There was no worry of that posterior capsule coming up. So now the cataract's been removed. There's no pieces floating around the AC. I'm going to turn off the automatic irrigation. And now we're going to switch to irrigation aspiration. Get that centered for you again right there. I'm advancing the steps to INA. And then again, I'm looking at the sleeve. And I want those ports pointing to the side. Now I'm removing that viscoelastic from the cornea. I'm going to remove some of the dispersive I put in because we don't need to protect the endothelium anymore. I mean, we always want to protect the endothelium, but we're not using phaco energy. And then where to go now? Where to go now? Go sub-incisionally because that's the hardest cortex to get. Go grab that and come to the middle. And there you go. This cortex, it's very, very kind of lightly adherent. It's very easy to peel. So I'm just going calmly, following what the eye will give me here. I'm gonna go back sub-incisionally here, and we're gonna go end up across from our incision. So now we've cleaned up all the cortex. There's two little wisps right there. I'm gonna zoom down a little bit, and I'll take away that those two little wisps of cortex. Okay, so we're all done there. So now we're gonna inject the cohesive viscoelastic. Here I go straight into the eye. First I check, and I'm holding my hands right here so that it doesn't go off. We don't want to inject and then it pushes the needle or the syringe. So I'm creating space. That's the anterior chamber. But now I'm going a little bit deeper under the anterior capsule to create space in the bag to inject the IOL. So now that eye is full of cohesive viscoelastic. Very easy to remove that, so we're not concerned. And my lens has been loaded by my very capable technician, Sylvia. Thank you. And then we're going to inject it with a wound assist technique like that. And then I use a push-pull or a Kuglen hook to just dial it into the bag. I make sure the little legs aren't stuck. They're fine. And then the next step is to remove the viscoelastic. So we get the INA handpiece again on the viscope mode, which just has a higher top kind of vacuum. And then I just sit here in the middle. You don't have to go. It's a cohesive viscoelastic. It's going to all come out eventually. You don't have to go digging around the corners of the eye, grabbing stuff. The chamber's a little deep, so I'm going to do a little bit of release of the iris like that. And I push on the optic, make sure there's nothing behind it. And then one more little pass around the eye here to make sure there's no pieces. Give me my second instrument. I'm looking at my paracentesis here, and I see there's a little bit of nuclear material. Push pull. Or yeah, so I don't know if you guys can see that, but there's like a little, that little guy right there. So we got that, and otherwise we're good. All right, so we're going to center that lens, and then I'm going to remove the instruments from the eye, and now the last step is hydration of the wounds. I'm going to hydrate with a Vigamox. That's Vigamox right there. Some of it went in the anterior chamber, and some of it was stromal hydration. So I highly recommend using an antibiotic intracamerally. It's been shown in big studies like from Aravind that it really decreases the risk of endophthalmitis. So we use Vigamox. And then I'm just doing hydration of the wounds. And then now I'm trying to attain a good moderate intraocular pressure. So we kind of feel, okay, the eye feels a little firm. So a little lot there. So I touch with my finger, feels great. So I think we're fine. Lens is centered. Everything looks good there. So we're done. So thank you very much. And we'll get the next patient ready. Thank you.
Dr. Lehmann, that was a beautiful demonstration. I really appreciated how you demonstrated the fundamental techniques of nuclear disassembly with the divide and conquer technique. Just some quick things while Dr. Lehmann's getting the next case ready. I really appreciated how he kept everything in focus and used trypan blue. Visualization is key. The other thing that I hope everyone saw was the little technique. Go back, this will be in the library. The little technique was named after Dr. Brian Little. It's not little as far as size, but it's a wonderful technique that you should practice as Dr. Lehmann did, not when there's a run out, but when you are in a stable case, because it's a wonderful way to rescue if you ever do have an anterior run out.
Okay, so we just showed divide and conquer. Again, so I've done some phaco teaching in different countries like Peru and South Africa. And when the folks come and they've done around 200 or 300 phacos, they all want to do the vertical chop because it's so cool to look at. But you really have much more motion in the bag, and you have an instrument sometimes going blindly under the iris. I really don't recommend it until you become an absolute expert in phaco. So these are just some videos of like a vertical chop. And it's really neat. Like I said, you impale the nucleus. Just for those of you that don't know it, you put a sharp instrument there and then you fracture it. So it's very nice when it works well, but I believe in the more difficult cataracts, especially the leathery ones, that this technique just doesn't work so great. You're unable to fracture it safely and you put a lot of stress on the capsule and the zonules. So that's vertical chop. Stop and chop. This is a good intro into chopping. Basically, you make the first trench and then you do like divide and conquer, you do a fracturing of the heminucleus. And then you remove the two pieces of the heminuclei. So here was just like normal divide and conquer. Here, the surgeon is just fracturing it, so you have two heminuclei, and then you impale the heminucleus here, and then use the chopper to kind of break it into the other quadrants. So this is a little bit of a combination of divide and conquer and chopping. So this would be a good intro into it, but you want to make sure you're with your biomed engineers and that your settings are right for chopping. It's not the same settings on the phaco machine as it is when you're doing quadrant removal, and so you need to really get those dialed in. So again, these are some additional techniques. All right, so we're going to talk now about conversion to extra cap. This may happen on the next case. The next case is a very dense cataract, history of dropped nucleus in the other eye, and I'm not sure I can even phaco it. If I think it's too dense to phaco, but maybe it isn't. So we're going to try to phaco, and then if I'm not able to phaco it, we're gonna convert to an extra cap. So what situations lead to extra cap conversion? You can think about this before you even get into the case. But what situations lead to it are things like the lens is too hard to phaco, or you get a radialized tear in the anterior capsule in a very dense cataract, or if you have poor visualization in spite of trypan staining, or if you have a PC tear and you can safely remove the nucleus, or if you have unstable capsular support. So these are situations intraoperatively that may lead you to convert to extra cap. But what happens in these scenarios is that you have a lot of stress and fear, and that's normal. And so you kind of freak out. So you have to think before you get in the operating room, like what can I anticipate and how can I change my surgery day to minimize all this stress and fear? So some of the folks over at Ames looked at what situations intraoperatively led them to do extra cap, and most of them were things like posterior capsular rupture, meiosis, prolonged phaco time. So those were the common scenarios. And things that you can identify. So this is the key thing. When you see these things, the little light bulb in your head needs to go off that you may have to worry about the case being harder than it is. And that's a rock hard lens that's either red or black, a tiny pupil, zonular laxity, a small AC, poor visibility because the cornea is scarred, and also patients that are older, like 80 and plus, you start to get worries like this. And so if you think you have these situations, it's a possibility, you want to schedule the case at the end of your list. And you also want to consider doing peribulbar instead of topical anesthesia. You don't want to try to do an extra cap or a small incision cataract surgery on an eye topically. It's just uncomfortable for the patient. Ideally, you could do IV access for more sedation for the patient. And then you want your team to be notified as well. You want to talk with the nurse and the technicians and all the additional instruments that you may need. They need to be on standby. You don't want to be yelling at them to go get stuff in the middle of a case and you're already stressed out. So you need to have a lens loop, a suture set, a crescent blade, bipolar, additional viscoelastics, all these things on standby already, as well as having a vitrectomy set and kinolog. And then if you're fortunate enough to have a mentor or a boss that's in the building with you, maybe have them come in for that case to give you some advice. Lastly, you can do a primary scleral tunnel. So that's what I'm going to do on this case that we're going to show. I'm going to start with a scleral tunnel, and then I'm going to phaco through the middle of the scleral tunnel, just in case we may have to enlarge it to do the cataract surgery. That way I'm not rotating, which you can do, which is rotate and make a new scleral tunnel, but I'm already kind of thinking that this is maybe ending up coming out whole through a scleral tunnel. So if I start my phaco through that, it could work fine. So conversion steps and tips. This is from Dr. Edding there at Iowa, this photo. This is how you're doing a subtenon. So if you start a case topically and it starts to go south and you have to convert to a small incision extra cap, you want to give some adjunctive anesthesia. And the best way to do that is with subtenon's blunt cannula. I like that best. You really can't stop and give a peribulbar at this point. You don't want to risk all that posterior pressure and everything. So you just cut down the conj and fear immediately. You create a space underneath tenons, and then you inject 2 to 3 cc's of lidocaine or bupivacaine. And so this is something you would want to practice, obviously, before you're in such a stressful operative situation. But this is a great anesthetic technique to use when you have to convert to extra cap in the middle of a surgery. Also, you want to make a new incision. Like, you're not going to extend your clear corneal wound and take out the cataract through a 12 millimeter like corneal incision. That's crazy. So, and this is a case that I was doing in Peru a couple of years ago, and with a lot of posterior pressure. And so I make my wound here, and you can see all that iris prolapse. So a lot of posterior pressure. There's different ways I could have handled this, but basically what I ended up doing was converting to an extra cap. And you don't want to do that like if you're sitting temporally to do the phaco, you want to rotate 90 degrees and sit superiorly to do the scleral tunnel. So that's another thing. You don't extend the clear corneal wound. You rotate your microscope and the body away from the phaco wound, and then you're gonna here I was gonna try to do another phaco superiorly, but you want to not do the scleral tunnel on the same side that you're already doing the phaco. When you want to remove the lens, like we're going to talk about, you're going to use a lens loop, and you need to have a large enough incision. So it can be kind of a trapezoidal tunnel, as we've learned in the M6 technique, where it's about maybe 13 millimeters in the internal lip and maybe 7 millimeters or so posteriorly. You want to choose a lens or an IOL that's silicone and that's 3-piece. You do not want to use a 1-piece acrylic lens, because this IOL is going to be placed up against the iris and the sulcus, and you don't want that acrylic material rubbing against the iris. So you want a 3-piece silicone or a 1-piece PMMA lens, ideally, in these scenarios. I mentioned here about using viscoelastic to remove the to push away vitreous if it's present. That's obvious. Obviously, you want to not be pulling on vitreous, but these situations are all very unique in terms of what stage of the surgery you may need help. So it's hard to give just overall advice in this scenario. So we're going to talk now a little bit about the management of a posterior capsular tear. So of course this can happen, and the importance of it can vary from not really relevant if it's a tiny little tear after the lens is in and everything's okay, to a big problem in which fragments of the nucleus fall inferiorly. So a posterior capsular tear, rent or rupture, is a tear in the posterior capsule, and the severity is definitely determined by what step of surgery it occurs. Okay, it's very stressful for the surgeon, and the consequences can be from 0, like the lens is already in and there's a small tear, to nucleus prolapse, patient requiring an additional surgery. It also means you have to take care of them a little differently postoperatively, which we'll talk about. But what's worse than a posterior capsular tear is a nucleus sitting on the retina. Okay, so that's kind of what we want to avoid. Again, the preoperative risk factors are those same things that we talked about for conversion to extra cap: a rock hard lens, small pupil, zonular laxity, etc. So the more difficult the case looks, the more risk of having one of these problems. And so again, these are the things that we can do if we anticipate a difficult case. So general tips for the posterior capsular rent management. Number 1 is to try to stay calm. Once you recognize there's a tear in the posterior capsule, your natural reflex is to like retract and run out of the operating room screaming, but you got to stay calm. You have to keep the fluid running, but you can have the technician decrease the amount of fluid that's running. Keep the phaco tip in the eye, and with your left hand, inject a dispersive viscoelastic in the area of the posterior capsular tear. It's better that it's dispersive because it will coat that area and it won't stay in one little glob that just falls posteriorly. So you want to coat that. You want to switch to low fluidics. And if you can, you want to finish the phaco with that viscoelastic tamponade. That, of course, depends on what stage in the case you have the tear. If there's still a big old hunk of nucleus, it's better to convert to extra cap and remove it. But if it's only a little bit of a fragment or a little bit of epinucleus, you can go ahead and try to tamponade the vitreous and finish it. Once you've removed the nucleus, before you put in the new lens, you want to do an anterior vitrectomy. Some pearls about vitrectomy. You got to learn the different modes on your machine. Okay, so most of the places that I go, y'all are using Alcon machines, and most phaco machines have the same settings. It's either cut IA or IA cut. You want to use cut IA. Some newer machines have a mode called anterior vitrectomy, which is what mode you would choose. Like if you have a Centurion machine, for example, that's a cut IA, but it goes directly to pedal 3 where there's aspiration occurring. So that makes life a little easier as well. But you only use IA cut if you're trying to remove like cortex. It behaves like an INA handpiece. So the things you want to use are either anterior vitrectomy or cut IA. You also want to close the chamber, so you would suture your wound and you'd make a separate incision, and you want to irrigate high, so you have fluid coming in high, and you want to cut down low. You don't want to be cutting and irrigating from the same incision, because then you're just having more vitreous prolapse to that area. Also, Kenalog is your friend. If you have the availability of Kenalog or triamcinolone acetate, you want to use that to stain the vitreous. and make sure you've removed all that you can. And also you want to remember to switch hands during the vitrectomy. You can practice doing vitrectomies in a wet lab by using an egg yolk with a little bit of cornstarch, actually, and it makes a pretty good vitreous substitute. Okay, so we're about ready for the other case. This may be a good time to take any questions that we have so far. Are there any questions?
Yeah, so James, I've been answering a few. One question is, what is your phaco machine?
So my phaco machine is the AMO Veritas. It's kind of the latest of the AMO machines, or the Johnson & Johnson Vision machines.
And one of the questions, I really appreciated how you kept the eye in focus at all times. How did you keep the eye centered, especially during trenching? I know that one of the things you did very nicely was free up the lens nucleus by hydrodissection and rotation. But how did you keep the eye, the globe, centered so that it was purely in line with the illumination during the case?
The tendency when you're learning phaco is you sit too close to the bed and your hand starts pushing the eye medially or towards, away from you temporally towards the nose. And so you have to just be conscious of having a relaxed wrist and kind of a relaxed arm so that you're not jamming the eye away from you. That's one of the most common things I see, and it can cause problems with visualization, and you're not able to be as efficient as you can be.
Yeah, I think another thing that I appreciated and you talked about is, as you're operating, keeping your hands very still. You don't chase the nucleus. You adjust your parameters, have the pieces come to you. I think one of the biggest mistakes I see people make is they try to go after the biggest quadrant or the biggest piece of the nucleus after they've done the divide and conquer. You went for the smaller piece. Could you explain why you did that?
It's like taking the jigsaw, the smallest jigsaw piece out, because once you get the smallest one out, all the other ones come easily. If you try to get the biggest, you're trying to get the biggest one out of the little hole there. So it just kind of makes things flow better.
I'm going to keep going through. I think what James mentioned is it's super important to not only do good hydrodissection, but do good lens rotation. The more mobile the lens is, the easier the pieces will be to manipulate when you're doing nucleus disassembly, and you're going to put less stress on the zonules. I think you saw
I'll pick a
during the
lens in a little
case,
bit.
as he was doing his first trenching, he was pushing the lens because it was a dense lens, and he went up in power to a dense lens setting. I think that's super important not to stress the subincisional zonules by pushing the lens if you're not getting good cutting and good trenching. Most people try to occlude the tip when they're learning to trench. Really, you should only have about 1/3 of the phaco tip covered with lens material so that you're not causing subincisional stress. I really appreciate what Dr. Gunva Al Turk just asked about using this technique for congenital cataracts. I think with congenital cataracts, each one may be different, and often the lens is not very dense. And so sometimes you'll open up the capsule and find out it's a very milky or liquidy cataract. So please know that divide and conquer really is more for adult cataracts, and congenital cataracts often need totally different surgical planning. So I appreciated what he asked about whether or not we could use divide and conquer for congenital cataracts. Please know, and I'll put this in the chat that we're going to have an upcoming webinar by one of our volunteer faculty from Columbia, Dr. Ernesto, about congenital cataracts. So in a few months, you can actually watch different techniques for congenital cataracts. So James, over to you.
It's Dr. Lehmann again. This is now our second case. This is Miss AG. If you hear me speaking Spanish to her, it's because that's her primary language. And you can see the very dense cataract, and you can see the pterygium here that didn't really have any effect on the Ks. So it's a tough one. This one's very like a brunescent cataract. Did you go over the history, Hunter, already with us on her?
I did not. I was just answering some questions. I think what's maybe you can do that now is that this is essentially a monocular patient who's had prior complicated cataract surgery in the left eye and a macular hole. So you're operating on the right eye. Is that correct, Dr. Lehman?
That's correct. Yeah.
And again, this is a very dense nucleus and one that we may need to convert. So I'll let you talk through that if there's any other teaching points. But I just wanted to, you had so many good pearls from the first case. I wanted to finish that.
Okay, sounds good. So we'll go ahead and get started. Basically, I'm going to start with a scleral tunnel because I have a feeling I'm going to have to convert to extra cap. So if I'm starting a scleral tunnel, I'm going to cut the conj down. So what I do is I grab near the limbus and I grab a little piece of conj like that. And then I pull anteriorly and I do a cut. She's an older patient, so she doesn't have much thick tenons. And I'm able to see the bare sclera there. Then I close the tines on my scissors, and then I kind of cut forward. And then I go back here and I free that up. So then I go again here, I'm freeing it up, then I open them, I pull anteriorly, and then I cut like that. So that's my kind of little conj flap I'm going to cut, and that should be sufficient right there. So now what I'm going to do is I'm going to do cautery. And then while I'm doing, yeah, I'll take the some BSS that I can drip off. So we're on the, how much power do you have on diathermy? 80, okay. And so I'm just trying to get all those little bleeding vessels. And then is it centered on the scleral tunnel area? You guys can see that, or should I move?
We see everything perfectly. Perfect
Okay.
focus, perfect centration.
Okay. So now we're good. We got those vessels gone. Now you can measure here if you wanted, but I kind of always know what size scleral tunnel I need to do. But first, what I want to do is I'm going to dry it with a Weck cell. I'll take 0.12s in my other hand. So 0.12s. All right. So I'm going to grab right here, and I'm grabbing a little bit of conj and a little bit of tenons, and I'm going to dry that area. Okay. I'll take the crescent blade. Okay. Now I'm holding the crescent blade, and I'm holding it upside down here, and I'm going to make a little groove right here in the middle. So one question that you always had when I was learning this is like, how deep do I need to make that? Well, that's not deep enough. You should start to see a little bit of changing color. So that's a little better. You can see a little bit of blue hue there. So that's about right. And now how do I know that? Just from experience, but essentially before it was too shallow. Now I see a little hint of blue there. So now I don't go just straight in like this. I'm going to go in at 45 degrees. I'm going to dig a little like this movement. Then I'm going to put the heel of that knife down and go straight up into clear cornea, but I'm not going to enter. And I'm not going to enter the AC. So you don't want the eye too firm for this, or you'll enter prematurely. So now I'm seeing the tip of my knife, and now I'm wiggling forward. I'm up into clear cornea. And now when I'm cutting to extend this, I'm not going to go forward. I'm cutting backwards. So I went down like that. That's when I cut. Now I wiggle forward again. Now I'm going backwards again. Okay, I'm going to go this side too. I'm going to need to enlarge the posterior lip. It's too small, which I'll do next. But I haven't entered the eye yet. And I'm cutting going backwards. So now my incision now is probably around, what's that, about 5 millimeters at that point. So I want to extend it maybe 2 millimeters in each direction. So I'm going to back cut like that, and then go forward using the plane of the eye as my guide. So now it's a bigger incision. And I'm going to go this way, cutting backwards and then back into the AC, then backwards again, and then into the AC. So that should be big enough to get that lens out if I have to. Okay, so now what I'm going to do, I'm going to use a 15-degree blade. I'm going to make a paracentesis just like normal. So 15-degree blade, please. 2.12 or Q-tip is fine, yeah. So I'm going to go ahead over here. All right. So I'm now into the eye. I'm going to make one on this side too, in case I have to do, if the staff could have bimanual INA on standby also, that'd be good, guys, if you okay. All right, so now I'm going to, this is a little bit of some lidocaine with epi. Thankfully, she dilates very nicely. It's a little bit of lidocaine with epi. Yeah, now we're going to put the vision blue in. Oh, this is a little big cannula. There we go. Okay, so we let that blue sit for a little bit. Okay. Like 1 Mississippi, 2 Mississippi. Okay, now we're going to rinse it out. While we're doing this, we're looking for clues about how stable that lens is. Like so far, I've put some instruments in the eye. The chamber's pretty deep. That's a little bit scary, but you're not seeing like that lens go up and down. There's no trampolining. I'm not seeing a lot of warning signs that it's very unstable. So it still may be possible to phaco, but you're learning all this while you're doing it. Now I'm injecting the viscoelastic, and then now I'm going to enter the eye with a keratome, 0.12 to the other hand. So now I'm going to go in my scleral tunnel, and I'm going to enter the eye just like I'm doing a temporal phaco. So I'm going to wiggle this in. I'm not going to cut. I don't want to be in a different plane. So I just have the heel of this down, and I'm wiggling up. Now I'm going to plane it out. I'm going straighter, And now I'm entering the anterior chamber. Okay. So that's just like a phaco thing. Let me see a little more viscoelastic. Okay. So I'm gonna put a little more viscoelastic. You saw the iris kind of went up here a little bit. So I think I could fill the AC a little more. And now I'm gonna go ahead and try to make as big a rexus as I can, even if I'm gonna have to phaco this thing, because if I want to convert to an extra cap, it would be nice to just not have to make any relaxing incision. So I want to go for a big rexus. There doesn't seem to be a lot of posterior pressure. So I'm able to get centered here. I'm gonna make my cut like I always do. You can see that thing is a dense cataract. It does not, you can see all the fibrosis and scary stuff there. So it's looking pretty dense. Okay. Okay, so now I'm gonna grab my rexus and then I'm gonna make it a little bit big, but not too big, because I can always do kind of a spiral technique. I'm always thinking one step ahead. I want it to go left, but I'm pulling down. And I want it to go down, so I'm pulling right. Now I'm regrasping. I'm gonna have it come up again here. So things it's going fine with the rexus, but I need to make that a bigger rexus. I'm not so concerned that the optic wouldn't be covered completely by the anterior capsule. So I'm going to try to make this pretty much as big a rexus as I can. So now I have like a little, it's a good technique here. So I have like a little strip here. I could just stop and finish it, but I want to keep going around like in a spiral so that it gets a little bit bigger. And since it's just a spiral, if I run into trouble, I can just easily kind of stop it. All right, so that's a pretty decent size rexus. Looks about 6 millimeters. So I'm removing that here. Now, I am going to try to gently hydrodissect, and let's see kind of what the behavior of the lens is. So far, it seems pretty stable. So I'm going to just lift up. It's really kind of fibrosed to the anterior capsule. Kind of just trying to break it, inject some fluid. The fluid doesn't seem to be going around. Maybe a little. I'm kind of just going under the anterior capsular lip. And let's see if I try to rotate it, what happens. Nothing. Okay. So what I'm going to do is I'm going to make my first trench, or I'm going to try to, and then I'm going to try to, I don't want to get too aggressive with the hydrodissection at this point. I want to see how the phaco is behaving. Put on dents for me. Okay, so I'm going to enter the eye again where I'm going to adjust my sleeve. And then I'm going to enter the eye. I'm going to go into just quadrant mode. I'm going to eat some of these air bubbles so that you guys get a better view. Okay, and then I'm going to go ahead and start phacoing. I'm going to go back to sculpt. So it's not much doing with the phaco. I'm able to get some of that. I can feel the phaco tip kind of getting a little warm in my hand already. Oh, there we go. I made a trench. I'm making a trench at least a little. I'm making some progress. What's the power setting on the phaco? 60? Go to 80.
80.
So I may attempt to crack it. I'm making some progress in the trenching here. I'll zoom in a little bit. Put some BSS on the cornea. So sorry, I'm not talking. Yeah, I'm just trying to be gentle and doing some trenching here. Trying to improve my view. I'm gonna go a little more laterally there. So if I'm able to crack it, I think there's a chance I'd probably be able to phaco it, but let's see. So how far to go down on this one? I'm starting to zoom down a little bit. I'm not seeing any red reflex still. I'm going to enlarge the width of my trench a little bit. Okay, there I'm seeing a little bit of a red reflex. Okay, a little more there. All right, so I'm going to attempt to crack it. So I'm going to insert my other instrument. Okay. Okay, I was able to crack it. You see like that leathery plate, but there's a red reflex down there. That's good. Now, since I made a crack in it, I can get a little more aggressive with the hydrodissection. First, I'm going to try to rotate it. And guess what? We can rotate it. Yay. All right, so it looks like phaco is probably going to work. Still, we're not out of the woods by any means. So I'm just going to take it slowly and easily. Just doing that other quadrant. So now I'm kind of know what depth to get to. So I have a good depth there, but a little anteriorly I could do better, like this part. So let's try to stick a second instrument in there and then break that fragment. It's got that leathery plate. Trying to fracture it. Okay, there we go. We got that piece clear, but it's still attached in the center. So I'm not going to get greedy and try to take that out right now. I'm just going to keep rotating. It's rotating easily. I'm not stressing zonules. I know they're still attached to a little leathery fragment here in the middle. So I'm going to go back to that first area where I was. And then I'm going to try to groove down to that same depth that I was on the first crack. And I'm not even at 100% power. I'm just at 80, and I'm not really even using all that. Some BSS, please, on the cornea. So those leathery fibers, you can see them down there. That was good. It's almost, there we go. We're separated there. And okay, last heminucleus here. I'm doing the same thing, just gentle strokes here. Try not to move stuff too much. Because it's completely free from the rest of the nucleus, it's kind of behaving a little loosey-goosey, but okay. And then try to, this one may be harder to fragment. Okay, so I'll tell you what I'm going to do. I'm going to try to take out a quadrant. I'm going to try to find the smallest quadrant. I'm going to leave that heminucleus because it's being a little bit funny to use. So I think the smallest one would be this one here on my right, that guy. So I'm going to go ahead and remove that. So I'm going to phaco 1, which is my setting to remove the first piece. I'm going to use my second instrument and gently push away this piece so that I can create more space. Going just right under the anterior capsule. And then I'm impaling it pretty good. I know it's dense. And I'm going to lift that little booger up into the AC. Now I'm going to switch to a mode called quadrant, which is a little more aggressive and not using a little more vacuum and a little less power so that the little piece dances on the tip a little better. But you can see the density of that nucleus. It looks like a little piece of, like a little Coca-Cola gummy bear thing. All right, getting that last piece like that. Okay, so now there's a little fragment right here. Okay, I'm gonna leave that alone. Go for this quadrant. I'm gonna go, again, I'm gonna align my tip. So I'm going straight like that. I'm not trying to grab it this way. And I'm gonna go right anteriorly, and I'm gonna impale it pretty good. And then I'm gonna lift it up and into the anterior chamber, right in the iris plane. Now my second instrument, I can use to crack it a little bit since it's such a dense piece of cataract. But basically what we wanna do is just be gentle, take it slow and easy, don't do anything stupid, and try to break up the piece. I always kind of look back at my phaco wound, make sure I don't see any burn marks. Now we did the scleral tunnel, so that's a little handier in that regard, but we don't want to, obviously anytime it's a dense nucleus, you can get a phaco burn if you get the tip occluded and you start to see smoke at the tip of the phaco. You'll start to see that that's a phaco burn, and that can be a real traumatic thing to fix, and we don't want to get a phaco burn. Thankfully, a lot of modern phaco machines, it's harder, but it's still possible. And again, when you see it, when you get occlusion of the tip and you hear the bell go ding, 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 ding. Okay, so here we are, last piece, the Big Daddy. It's kind of a lot of manipulation. If I try to make a groove in this and crack it, it's gonna be pushing a lot on the peripheral zonules and everything. So I'm gonna try to remove it all in one piece and just do like a chop of that quadrant into quadrants. So I'm gonna elevate it. I bring it halfway up, then I'm gonna re-grab right in the middle of it. And I'm gonna impale it. And I'm gonna bring this other nucleus bring my chopper to it. It's tough to chop. There we go. I'm able to chop it there. Okay, now we're just going to go slow and easy and get these remaining connection. Okay, so again, slow and easy. Sorry if this makes for boring TV. Just trying to take it slow and easy so that nothing unexpected happens. And here, it's always good to visualize the tip. I let that one kind of get under a little bit, but it's always better to see what that tip's doing. And try to keep the piece dancing on it. Instead of stuck in the middle like that, you kind of want it on the side. So use your second instrument to kind of push things around so that it's not just impaling in the middle of the quadrant. All right, so we got this last piece coming. So far, so good, guys. I'm gonna remove my second instrument. I don't need it anymore. Like I showed you in that other video, it's safer to just have one instrument in the eye so that you have better fluidics. Now that one's kind of stuck in the corner, so I'm gonna put my second instrument in and push it away a little bit. This is my breaking my rule about going chasing something, but I got to get that little piece. So it's not wanting to come. So I go back to phaco 1 and I'm going to just use as much vacuum as I can. The power is repelling the piece, or the piece is stuck partially in the paracentesis. So we're going to try to get it. Okay, there we go. Now I'm bringing it centrally. Oh, okay. I'll tell you what, why don't I move this all the way like that? There we go. There we go. Take it off dense. There's always a kind of a play between the, okay. I took it off dense. Okay, I took it off dense because sometimes that has too much power and not enough vacuum. And that little piece doesn't want to, doesn't want to come to phaco tip. Okay. There we go. Let's use the second instrument to kind of help it. How about that? I've seen this before. Let's do this. What's my decrease the power? Go back. Decrease the power. 30. Okay. Take it to 10. Okay. What's my aspiration? It's at 42. Let's go up to 80. Okay, so what I did was decrease the power, increase the aspiration, hoping that it would. Wonder if there's occlusion of the phaco tip. That could be what it is, and it's not able to aspirate. I'm gonna remove the phaco from the eye, and then let's let me just do it in a. Okay, we're gonna try to rinse the phaco tip. Sorry about that, guys. I think it's blocked, and maybe it's not aspirating. Is what's happening. You guys can normally open up the ZCBU lens. Yeah, so we're just flushing the phaco tip, trying to get any kind of piece that's there. Why don't we get another phaco tip, just phaco tip, not the whole phaco hand piece, just in case. We'll go back into the eye, try to get that last piece. Thought we were clear, but we're good. Don't panic. Everything's okay. And then, okay, that's a little better. Let me see second instrument. I think maybe there was a piece occluding it and it couldn't aspirate, but it wasn't going ding, ding, ding. Oh yeah, here we go. We're good now. All right, guys. Go back to the setting before. All right, that's what it was. So there was a piece inside that wasn't, it was just decreasing the aspiration enough to make it where I couldn't aspirate the piece. All right, in irrigation aspiration, go ahead and load the lens. So when that happens and it's bouncing off the tip like that, got to do some troubleshooting. And so it looks like there was a piece that wasn't enough to make the ding, ding, ding go, like it was occluded, but it was enough to decrease the aspiration. So they were just repelling the phaco tip. So we're in INA, yep. Okay. We're getting these little cortical wisps. All right, so far, there we go. Cortical piece over there. There's some subincisional cortex here. I may see, I don't want to grab the capsule like that. So I'm going to let that sit there. And then I'm going to come back and get it when I'm got a lens in the bag safely. So now cohesive viscoelastic. Gonna open that. Let me see a little bit of this stuff. Yeah, we're going to put a little more cohesive in. There we go. Now I'm injecting the lens. We're going to use a suture. You just go ahead and get that suture ready. Yeah. All right. So while I'm doing this part, if Hunter, if you want to get, if I can field questions while I'm just kind of tidying
Yeah,
everything up here.
I think a lot of people, I think you did a beautiful job of preparing for conversion, but we stayed with phaco. How did you protect the cornea? Reapplying OVD, using high quality irrigation, phacoing in the bag. What are some other things you did to protect the cornea? And why did you decide to start with phaco and not just go straight to small incision?
Well, I'm better at phaco than I am small incision, number one. Number two, I was able to make some progress pretty fast. So I thought, you know, even if you do a great small incision extra cap, there's still a chance that you can, you may have to enlarge the rexus, you may have a radial tear. There's a little more kind of, at least in my hands, a little more uncertainty than a phaco that's going like steadily well. I'll take the INA now. So that's why I did it. Now, I um I probably should have stopped and applied some more dispersive viscoelastic. That would have been a good idea. Uh, but what's our total energy there?
Vacuum is at 525.
The
That physical 3 was
103? Okay, so we did use quite a bit of energy. That would have been a good thing to do. That's a good point from the audience. I guess I was kind of so caught up in the not not breaking any caps or anything that I didn't think to do that, but that's a great point. Reapplying dispersive viscoelastic, always a good idea. What other questions?
Yeah, so one of the other questions, so I think we've answered that one. I think one of the things everyone is asking is when someone is a beginning surgeon, this is from Dr. Ahmed, if someone is a beginning surgeon and starting their first dense cataracts, what are some techniques or some things you demonstrated that you'd like them to be able to do? What are some things like making sure you're ready to convert, surgical planning, protecting the cornea? What are some other tips or tricks that you'd recommend if someone is doing their first 3 or 4 plus dense nucleus?
I mean, I think having like those things we talked about, put it at the end of your list so you're not going to derail a whole day, right? Have a mentor nearby, kind of have a plan B, have all your other lenses in the room that you may need in different scenarios. And surgically wise, if you're trying to phaco it, then you need to verify that you can rotate the lens before you start moving on to more complex steps. I would definitely do the divide and conquer, and once you're able to crack that first trench and move the eye, you're kind of out of the woods in terms of kind of any kind of scary factors that could happen. Notwithstanding like a lens. Let me see the needle drivers.
You
Notwithstanding some sort of inadvertent tear of the posterior capsule through being rough.
I want to make sure you heard a shout out from Dr. Funmi. This is typical of an African cataract. You did a great job. Thanks for this life example of a dense and difficult cataract. So a big shout out to you, James, and a big thank you to Dr. Funmi. Dr. Morteza wanted to know what surgical microscope are you using?
It's a Leica. It's not the newest model. It's probably around 15 years old. I love it. It has the best optics of any scope I've ever used. I hope the new ones, when this one breaks, that are just as good as this one's been.
And
Tires.
one question, Dr. Pandy asked, is that a 9-0 nylon suture? What suture material are you using, Dr. Lenny?
10-0 nylon.
That's what I thought. Okay, so it's a
Yeah.
10-0, not a 9-0. I just want to make sure
Yeah.
we got that live answered.
And I leave this one, and I'll remove it at a week, this conj one. And that one that's in the sclera, of course, that just stays.
And you're getting more shout outs, including Dr. Gonzalez. So I just want to make sure, James, we all appreciate you doing a challenging case, not the typical Southern Florida, Southern California cataract.
Oh.
One of the things I think that Dr. Krishna Kumar is commenting, he says it's most important to debulk the nucleus, especially in a very dense cataract. And I think that's what you did, is you got that first crack, and that was going to determine your surgical plan. If it was not dividing well, rotating well, you probably would have converted earlier, but you were able to get that trench going, get the crack, and you did a beautiful job of debulking that central nucleus.
Well, thank you. Yeah. So if I'd run into trouble, like that, I just start pushing the nucleus away from me and I'm not making any progress, then I probably would have done a can opener style Rexus and opened it up and just converted to an extra cap. But again, like I don't do those routinely. So a doc in India or in Africa or something like that, they would probably have more success doing it that way. But I would feel like I still run the risk of having a PC tear higher in that scenario than I do if I try to keep phacoing. And once I knew I could rotate it, I knew I was that I was pretty good. So,
So James, two more because I realize we're at the top of the hour and you need to get on with your surgical list. When is it an absolute no to phaco? Someone with low endothelial counts, someone who's not cooperative. Where are some absolutes where no matter how good you are as a phaco surgeon, you're going to say no and go straight to small incision, not even attempt dividing
if it's
contour?
wobbly, if the lens is wobbly, like you start to see that the lens is wobbly, you really can't phaco that. You're just gonna cause problems.
So zonular concerns, corneal concerns, or if you're not comfortable, those would be probably your three automatic no-goes, go straight to small incision.
Yeah, I think so. Or if there's any history of like phacodenesis, or if you kind of can already see that the capsule is weird, or that there's some sort of anything that would show you the instability of the lens. If an AC was very complex, very small, something like that, that would also make me not be able to phaco it, I think.
And we have two more quickies because I know you need to go. Was this patient under local anesthesia or was there a retrobulbar block? That's one question.
I
And
did a
then
block.
okay,
Block.
you did block them. Okay.
Yeah.
And then what influences the choice of silicone versus acrylic IOLs? This is from Dr. Eni. They wanted to know what influences your choice of silicone versus acrylic. And I think that will be our last question because I know you need to go. And I'm going to jump on a 15-hour flight to join the Flying Eye Hospital team in Mongolia.
Awesome. Yes, if it's going in the bag and the Rexus is intact, you can do acrylic. Otherwise, do silicone. That would be my advice.
I
So
know
like if it's going to
Dr.
go in if it's going to go in the sulcus, silicone is better for the iris. Acrylic I only like, especially one piece acrylic if it's an intact 360 anterior capsule and you know it's going in the bag.
I need to apologize to Dr. Mohammed. He did ask if you use the OSI opacity index pre-op to determine whether or not phaco versus small incision. Do you?
No, I don't. I don't do that. No.
Yeah,
But
I think
it's nice.
I think that's one of the factors you consider, right? How dense is the nucleus? How sick is the endothelium? Are there zonular concerns? How comfortable are you? I think it's a constellation. I don't think there's always a single thing, but if you're ever not comfortable or there's a risk factor that you can't control, then absolutely. I know James, how are we for time? Do we have another minute?
I think we should probably be wrapping it up.
Okay. So again, Dr. Lehmann, we can't thank you enough. I want to thank our audience. This was an absolute great. I think we answered 45 questions for you, Dr. Lehmann. So you owe us. We want to thank you for doing the Bob Ross narration. You kept your voice very calm, very smooth. And the thing I really loved was how you troubleshot when that last little piece wasn't coming. You thought through the problem. You didn't rush. You didn't get frustrated. You went through a checklist of, what is going on? Why is this not working? So certainly, I want to give you a shout out for staying cool, calm, and collected, and thinking through a problem and not getting frustrated or jumping to a solution that may not have existed. So thank you all. I really want to thank both Andy and Lawrence from the CyberSight team for staying with us and helping us. Dr. Lehmann, I want to thank you. I know you've been traveling a lot. I want to wish you good luck with the rest of your cases today.
Thank you very much. Thank you,
Take
Orbis World.
care.
Appreciate it. Thank you. You did a
Take
great
care.
job. Thank you.